And before we get started, we do have an upcoming CHETChat next month with Dr. Andrew Papachristos. This is regarding his work in gun violence prevention. So please save that date. That will be on Tuesday, May 19th. So save the date. We'll send you more information over our newsletter. Also, we have a mini series. If you haven't checked out our podcast, Skinny Trees Podcast, Lift Health for All. We have a mini series ongoing right now, COVID-19 in our Chicago communities. So if you have a lot of time right now, go ahead and check us out. We're on Apple Podcasts or wherever you listen to podcasts and SoundCloud. Check us out if you're at home. Take some time to listen to a few of our episodes, and we will be releasing a few more weekly. Today's CHETChat is about mental health in the Black community, and we're happy to feature Dr. Inger Burnett-Zeigler. Dr. Inger Burnett-Zeigler is a licensed clinical psychologist and associate professor in the Department of Psychiatry and Behavioral Sciences, Feinberg School of Medicine at Northwestern University. She utilizes traditional psychotherapy and complementary and integrative health approaches to help clients with mood and anxiety disorders, stress management, interpersonal strain, and overall mental and physical wellness. Dr. Burnett-Zeigler is passionate about eliminating mental health illness, stigma, and assuring that all individuals have access to high-quality, evidence-based healthcare. Her research focuses on examining factors associated with access and engagement in mental health, service utilization, and using this data to develop, test and implement acceptable and accessible evidence-based interventions in community-based settings. Her research has been funded by the National Institutes of Health, Agency for Healthcare Research and Quality, the Veterans Health Affairs, and the Greer Family Foundation. Dr. Burnett-Zeigler's op-eds have been featured in the New York Times, Time Magazine, The Hill, Chicago Tribune, and she has appeared on CNN, WGN-TV. She is on the board of directors for several large healthcare nonprofits, including Heartland Alliance Health and Thresholds. She is a proud lifelong Chicagoan. Welcome, Dr. Inger Burnett-Zeigler, and thank you for joining us.
Thank you so much for having me. It is my pleasure to be here. I'm going to go ahead and start sharing my screen. Okay, I'm asking the host, is the screen being shared appropriately?
Yes, we see it.
Okay, wonderful. So again, thank you for having me. I hope that you all are all well in your respective homes today. Today I'm going to be talking about the intersection of race, gender, and poverty and mental health in the African American community. Kimberle Crenshaw first coined the term intersectionality in the late 1980s. And when she coined this term, she was using it as a means to discuss the combined oppression of racism and sexism in Black women. In a paper that she wrote for the University of Chicago Legal Forum, she stated that traditional feminist ideas and anti-racist policies exclude Black women because they face overlapping discrimination unique to them. She went on to say, because the intersectional experience is greater than the sum of racism and sexism, any analysis that does not take intersectionality into account cannot sufficiently address the particular manner in which Black women are subordinated. While Kimberle Crenshaw is widely credited with coining the term of intersectionality, she is not the first one to use this term to talk about the combined effects of racism and sexism, specifically among Black women. In 1981, in the book Ain't I a Woman by Bell Hooks, she stated the struggle to end racism and the struggle to end sexism were naturally intertwined, that to make them separate was to deny a basic truth of our existence, that race and sex are both immutable facts of human identity. Today, intersectionality is used to discuss the combined oppression experienced by multiple disadvantaged identities. While intersectionality was kind of originated around sexism and racism experienced by Black women, now when we talk about intersectionality, we're also talking about education, income, sexuality, ability, age, class, language, culture, and the like. Again, today I'm going to be focusing my conversation on the intersectionality of race, culture, ethnicity, and gender, and these combined effects on mental health in the African American community. A number of widely known epidemiological studies have shown us that when controlling for income and education and other socioeconomic factors, in general, African Americans are less likely to have the most common mental illnesses like depression and anxiety. This table here shows us when we look at combined all mental illnesses, when we look at major depression, and when we look at generalized anxiety, African Americans tend to have lower prevalence rates of lifetime prevalence rates of these disorders. In a paper that my colleagues and I put together some years ago, we examined the impact that ethnic identity might have on the prevalence of lifetime psychiatric disorders among Black, Hispanic, and Asian adults. In this paper, ethnic identity was describing racial and ethnic pride, the importance of racial and ethnic heritage, shared racial and ethnic values, attitudes, and behaviors. Acculturation was really measuring language and social preference. And what we found in this paper was that higher scores on ethnic identity were associated with a decreased odds of having a lifetime psychiatric disorder for those who were Black, Hispanic, or Asian. On the contrary, higher scores on acculturation were associated with increased odds of having a psychiatric disorder for those who were Black, Hispanic, or Asian. And we thought these findings to be really interesting and important in terms of understanding the unique role that having a sense of pride, having a connection to one's culture and ethnic values might serve as a protective factor for the prevalence of long-term lifetime psychiatric disorders. I just mentioned that a number of large epidemiological studies have consistently demonstrated that when we look at prevalence rates of mental illness overall, and specifically the most common mental illnesses, depression and anxiety, that the rates for African Americans tend to be lower than the general population overall. But those studies are controlling for a number of social determinants of health that can be risk factors for mental illness. When we think about socioeconomic position, we know that unemployment, lower average income, and living below the federal poverty level increases one's risk for mental illness, as does having fewer years of education, the experience of chronic and acute stress, racism and discrimination, and having poorer access to the healthcare system. And so when we reconsider how racial and ethnic minority populations actually exist in society, we know that a lower percentage have a college degree, there are higher rates of unemployment, there are lower average income, higher rates of poverty, and there are higher rates that are uninsured. And in fact, in our communities, we cannot disentangle the role of race and the way that it interacts with social and economic factors. And so for these reasons, African American populations tend to be at greater risk for a number of the more common mental illnesses like depression, anxiety, and trauma. We can't think about the role of health outcomes in general and mental health outcomes specifically without taking into account the context that individuals live in. I have 3 neighborhoods presented on the slides here. The neighborhood on the left, 60619, that is in fact my childhood home in Chatham, where 96% of the residents are Black. About 28% live below the federal poverty line, and the life expectancy is 72 years. If we go up the road, up the lake, just a bit to the Oakland neighborhood, which is still on the south side of Chicago, this is the zip code that's identified as 60653. We still see that the majority of residents are Black, about 93%. About 36% are living below the federal poverty line, and the life expectancy is at 70 years. And if we continue right up Lakeshore Drive and come to 60616, where many of us would typically be working, where the majority of residents are white, about 72% are white, the household poverty level falls to about 12%, and the life expectancy increases about 11 years to 83%. And so what this is really demonstrating is that neighborhood context is important in terms of access to resources and in terms of risk factors for our health. We know that the neighborhood that one lives in also plays an important role in terms of the stressors that they may be experiencing. The APA puts out an annual Stress in America report. And in one of their recent reports, they identified the top 5 stressors as being money, work, the economy, family responsibilities, and health. We know that African Americans tend to experience additional stressors on top of those that have been identified by the APA report, including racism and discrimination, concerns about personal safety, daily hassles with just getting around, hassles by the police and so forth, experiences with traumatic events, living in poverty, and unemployment and employment security. We further know that these social and economic stressors are compounded in the experience of many Black women, with about 1 in 4 Black women living in poverty, 9% being unemployed, and 2/3 of Black children living with a single mother. And I highlight those particular statistics to really underscore the additional stress that ultimately impacts not only the mental health, but the physical health among African Americans in general and Black women specifically. So continue our discussion around racism and discrimination. We know that about 2/3 of Black and Hispanic adults report being discriminated against daily. That discrimination including being treated with less respect, threatened or harassed. And those that experience racism and discrimination tend to be more stressed, and that stress has an impact on the physical body where the body is producing more of the hormone cortisol. And that physical as well as psychological consequence of stress has real impacts attention and concentration, and one's reduced ability to perform at school and at work. A couple of years ago, the Georgetown Law Center put out a report called Girlhood, where they talked about the adultification of Black girls. And this report really identified how certain discrimination practices, particularly among young Black girls, start early in childhood. This report found that among the individuals that they surveyed, people identified that Black girls needed less nurturing, protection, support, and comfort, and believed them to be more independent, know more about adult topics, including sex. And these discriminatory beliefs about Black girls had negative consequences. Down the line, it contributed to harsher punishment, fewer opportunities for development among these girls, disproportionate involvement in the criminal justice system, and harsher penalties. We also know that Black children, as well as Black women and adults in general, are more likely to be exposed to trauma. Black children have more experiences with childhood maltreatment, physical and sexual abuse and neglect. And Black adults have the highest number of cumulative traumatic events. 40% of Black women as compared to 30% of white women experience intimate partner violence. Black women and Black men have higher rates of PTSD. And poverty increases the risk of exposure to violent crime. I'm sure many of you have seen these maps many times before, and despite what may be being displayed on these heat maps, when we look at the Chicago heat maps, typically, often, unfortunately, the patterns are the same. This particular heat map is displaying on the left side, homicides across the city, and on the right side, poverty rates across the city. And in these maps, we can see concentrations on the west side and the south sides of the city in the homicides, as well as in the dark green areas, higher rates of poverty. The area that has been circled in yellow is that community, the Oakland community that I referred to a few slides ago, that we examine in my research studies. And so I want you to just kind of hold that in mind. That was the middle community on those three maps that I spoke about just a moment ago. And so, as I mentioned, I conduct my research in the Oakland neighborhood that is on the south side of Chicago. And if you know the south side of Chicago, it's just north of Kenwood, just north of Bronzeville. It's at about 43rd and Cottage Grove. And this is the area where I do my research that is focused on implementing a mindfulness-based intervention in a population of majority African-American individuals with depressive symptoms that tend to have less access to mental health care. If you look at the three columns that are presented in this table here, it provides some information in terms of the demographics of our research study, the demographics of the neighborhood, the Oakland neighborhood, and the demographics of Chicago at large. In our study sample that was recruited largely from the Oakland neighborhood, about 43% of the participants are in single mother households. The majority have not completed college. They either have some college or a high school education. It's about a 26% unemployment rate, and about 37% are living below the federal poverty level. These statistics are pretty much aligned with that which is seen in the broader Oakland neighborhood, with about 34% being single mother households, the majority having a high school education or less, about 26% unemployed, and about 40% living below the federal poverty level. You can see that the characteristics of our participant sample, as well as the neighborhood, are different than that of the Chicago characteristics overall, where there's about only 13% that are in single mother households, about 41% have a high school education or less, 11% unemployment rate, and 23% living in poverty. So when we compare Oakland with the city overall, it is under-resourced. However, if you've ever seen kind of those listings of the Chicago neighborhoods in terms of crime and violence and other factors related to neighborhood safety, it falls about in the middle on that list. As you can see, it says Oakland ranks 28th for violent crime, 11th for property crime, 17th for quality of life crime among the 77 Chicago neighborhoods. So in that particular sample of participants that were enrolled in some of my research studies, which I'm not going to go into detail about today, but I do want to share some information about the rates of trauma that we found in those studies. And we found in our pilot studies that about 51% of the women, who were all African American women, reported having some trauma exposure. 29% met clinical criteria for post-traumatic stress disorder. An additional 7% were sub-threshold for PTSD. So what I mean when I say sub-threshold is that they reported having a number of symptoms of PTSD, but didn't meet full criteria to full diagnostic criteria for PTSD. The traumatic experiences that these women largely reported were physical or sexual assault, domestic violence, and trauma related to murder or death. And this is significantly higher than the numbers of PTSD that are reported in the general population, with about national estimates being at about 7% for a lifetime diagnosis of PTSD. Studies that have looked at prevalence of PTSD in what's described as disadvantaged neighborhoods have reported rates at about 20 to 22%. And so the Oakland neighborhood is having, looks like they're reporting even higher rates of trauma exposure and PTSD symptoms. We went on to look at the exposure to trauma a little bit in more depth in our sample. And we found that 89% of participants experienced multiple types of trauma, with an average number of types of trauma being about 5. 47% experienced sexual assault, and 61% experienced sexual assault or an unwanted sexual experience. An additional 72% of participants experienced interpersonal violence or assault. I think it's important to underscore this because when this data initially came out, which was about 3 years ago, there was a fair amount of attention given to this paper, given the neighborhood on the south side of Chicago and discussions about violence in that neighborhood. And while we know that exposure to violence and violent episodes tends to be greater in some south side and west side neighborhoods, I don't want us to lose sight of the role that other types of trauma are also playing in these neighborhoods. And so it's not just exposure to gun violence, but also exposure to intimate partner violence and physical and sexual assault still tends to be a significant concern. We know that stress impacts the body, not only traumatic stress, but those other types of stress that were discussed. Stress can lead to increases in irritability and anger. Stress is highly associated with depression and anxiety. Stress shows up in the body, and a lot of folks are noticing this now with the stress of COVID-19, increased headaches, fatigue, gastrointestinal issues, muscle tightness and tension. And stress can also show up in behavior, with it being more difficult to sleep at night, picking up unhealthy eating behaviors, eating more snacks in the day, or self-soothing by eating, as well as substance abuse. And stress is also directly associated with health outcomes. We know that there are a number of health disparities, not only in mental health, where white individuals have a life expectancy of about 4 years more than Black individuals, with the life expectancy being 79 versus 75 years old. Stress is strongly associated with other health outcomes such as maternal mortality, low birth weight, preterm birth, miscarriage, cancer, cardiovascular diseases such as hypertension, diabetes, obesity, and opioid deaths. So stress is not only important when we think about our mental health, but also important in terms of thinking about physical health. The role of stress as it pertains to maternal mortality has been the subject of a lot of news in recent months. And, I think it's really important that this topic is getting public attention and also legislative attention. And this chart is really just demonstrating that American natives and Black women are 2 to 3 times as likely to die from a pregnancy-related cause than white women. And we can see this pattern dating back to over the last 10 years or more. Arlene Geronimus put forth what she called the weathering hypothesis. And this was really a hypothesis that she used to describe the way that stress impacts Black folks such that it ultimately deteriorates their health over time. She reported that Black adults experienced early health deterioration as a result of repeated exposure to social and economic adversity, and we've discussed some of that already. And she used this weathering measure, which included 10 biomarkers related to stress, including blood pressure, cholesterol, and body mass index. And in her research, she found that Black women were more likely to have a high weathering score, meaning that their physical biomarkers related to stress were deteriorating more rapidly. She found that by age 45, 50% of Black women had a high weathering score, and these scores were not fully accounted for by poverty. We know that in addition to the role that chronic, acute, and traumatic stress has on physical and mental health, we know that disability for mental illnesses seems to be increasing over time. And this graph here is demonstrating where mental illnesses fall in terms of disability payments over the last 30 years or so. Unfortunately, we're seeing negative increases in mental health outcomes in a number of different mental health outcomes. And so we know that suicide rates for African Americans have had a slight increase over about the last 30 years, and a quite significant increase when we look at not only rates of suicide attempts, but also suicide completions among African American youth, Black youth. This is in contrast to studies that have found that white, Hispanic, and Asian American youth have had a decrease in suicide attempts. Not only are we seeing an increase in attempts and completions, but we're also seeing that attempts are leading to more serious injury among Black boys. And this data comes from a report that was put out by Pediatrics just this last November. So we know disability is increasing, suicide is increasing, as are opioid deaths. And the trends for opioid deaths, unfortunately, are similar, where we see a greater proportion of African Americans in Illinois experiencing opioid-related deaths as compared to the white population in Illinois. It's widely cited that criminal justice is one of the largest providers of mental health care, particularly in Chicago, but also nationwide. And this is just some data to demonstrate that when we look at the prevalence of African Americans in the criminal justice system, we also see that there are disproportionate numbers in the criminal justice system that are experiencing psychiatric disorders, and those are the last two columns there. So we know that African Americans are at greater risk for a number of psychiatric conditions. That is in part due to some of the social determinants of health that we have already discussed: income, education, access to healthcare, insurance. And these populations that have the greatest levels of need are also often those who are less likely to access the mental health service system, whereby those that are male, younger, racial and ethnic minority in general, and African American and Hispanics specifically, with fewer years of education, less income, and living below the federal poverty line, and those who are uninsured are least likely to access mental health services. While only about 40% of those with need in general across the national population receive mental health services, within that, Black and Hispanic adults are even 50% less likely than whites to receive treatment. We see disparities in the ways that healthcare is provided overall. And that disparity is due to a number of different factors if we look at operations, if we look at providers, and if we look at individuals. Some of the explanations for that disparity in healthcare is due to how healthcare systems are operated. So thinking about who gets care, where that care is placed, the communities that that care is available in. Discrimination at the individual patient-provider level. So how providers might understand the needs of minority populations. There's been a lot of studies that have looked at how providers tend to underestimate the pain experienced by Black patients and not prescribe pain medications at an equitable rate, leading Black patients to experience more discomfort. This discrimination at the individual and patient provider level has also been discussed in detail when looking at the negative pregnancy outcomes specifically among Black women that we talked about a little while ago, in terms of thinking about how providers are understanding the experience that Black women are having during pregnancy and during delivery, and really honoring the self-report of their experience in a way that is adequately meeting their needs. We see these disparities in healthcare across illnesses and across healthcare services. And we see them based not only on race and ethnicity, but also on socio and economic factors. Unfortunately, disparities in health outcomes are not improving. The following 5 graphs are looking at health and disparities over about the past 30 years. We see that average health is not improving. Income disparities overall, when we look at that yellow line, which is the US average, are not improving. Disparities among Black and white adults are not improving. And health equity, right? So the way that we decrease that gap in health outcomes among Black individuals and white individuals, that is also unfortunately not improving. just to kind of go back for a moment to talking about mental health specifically and the way that mental health services are available and barriers to access and engagement in mental health services. We can look at the way that mental health services have been distributed specifically in Illinois for about the past 10 years. Many of you might be aware that in between 2009 and 2012, there were some major cuts in mental health funding, for mental health services. Over $100 million in cuts were funded. This received a lot of attention and a lot of backlash even today with our most recent mayor. And this led to fewer state-funded services. And with these decreases in funding and services, we saw that ER visits increased, nights in the homeless shelter increased, and incarceration rates increased. Here's another map. You guys see that I like maps, and this map is demonstrating, it's a heat map to demonstrate where there are the most safety net providers. So the darkest areas are the areas where there are fewer safety net providers. So in other words, the areas where there are darker red colors, there are fewer healthcare services available. And here we just see where those mental health centers were located that closed. So there were 2 that were on the north side that closed, and 2 on the south side, and 2 on the west side that closed. And there are 6 that still remain open. Just at the end of last year, there was a pretty unprecedented increase in mental health funding that was put forth by Mayor Lightfoot, where the budget passed for an increase in $9.3 million in mental health funding. And this funding is being used to support mental health in 3 prongs. One is to fund existing community health centers in order to expand mental health services. And those health centers include federally qualified health centers and other organizations that already exist in the community that are doing a lot of this work around mental health. The second prong of this funding is to support a mobile crisis intervention team. And this is really to have money available for trained individuals to go out into communities that are experiencing higher levels of trauma, specifically related to gun violence. And then finally, to create a helpline through the 311 number to help link people to mental health services. And what the group that kind of put together this plan, which I have to acknowledge that I'm a part of this, really discovered was that, there was a problem with availability of resources, but there was not only a problem with availability of resources, but there was also a challenge of people knowing where resources were. So while there were certainly gaps in neighborhoods in terms of having mental health resources available, there were also resources that were available that were being underutilized because people didn't realize that they were there. And so the prong 1, expanding services, is to help address that gap. And then prong 3 is to help connect people to the resources and communities that already exist. So I mentioned that only about 40% of those with mental health need actually get treatment, and there are a number of reasons for that. Some of those reasons are related to cost, insurance coverage, structural barriers like the actual availability of a resource in your neighborhood, transportation, and childcare. And those types of barriers are what I like to think about as concrete barriers, right? So these are actually tangible barriers to being able to access the resource. Additionally, there are psychological barriers to mental health care or healthcare in general, related to negative attitudes and beliefs about mental health treatment. When I think about these psychological barriers, I'm thinking about things like people not perceiving a mental health problem or a need for treatment, thinking the problem will get better on its own, wanting to solve the problem on your own, believing mental health treatment will not be effective, shame and embarrassment, having concerns about taking medications, thinking it'll be addictive or you might experience side effects, mistrust, right, which is often talked about specifically in minority communities, mistrust of the healthcare system, what's going to happen to the information, who's going to have access to the information, how might this information be used against me. And a number of qualitative studies have reported that Black adults tend to have more negative attitudes and stigmatizing beliefs about mental illness and treatment, experience more shame and self-blame associated with treatment seeking, and higher levels of medical mistrust. I mentioned that paper earlier where we looked at the role of ethnic identity and acculturation on the prevalence of psychiatric disorders. And we did a complement to that paper looking at those same factors, ethnic identity and acculturation, on the role of participation in psychiatric services. And while we found that a higher ethnic identity was associated with a decreased prevalence in psychiatric disorders, we found the reverse effect when it came to participation in treatment, whereby higher ethnic identity scores were associated with a decreased odds of using psychiatric services for those who are Black or Hispanic. Again, ethnic identity was looking at identification with others of those of the same ethnicity. Most of your friends are the same ethnicity, more socially comfortable with people of the same ethnicity. Ethnicity plays a big role in your social interactions and shared attitudes and behaviors. On the flip side, we found that higher acculturation was associated with increased odds of psychiatric service use for those who were Hispanic. And again, in this measure, acculturation was looking at racial and ethnic social prevalence and whether you were born in the United States or not. So we found these findings to be really striking, particularly when looked at side by side with the other report that looked at the prevalence of psychiatric illness, and understood that for some, something about identifying with your particular ethnicity and culture might stand in contrast with actually going to get mental health need. And when I thought about that, I thought about, kind of sayings that people may say, like, for example, Black people don't go to therapy, or that's not something that we do, or I would be ashamed to tell somebody. So it's really thinking about kind of how the idea of participation in mental health treatment is, one perceives that as being understood in your culture. And on the other hand, when we think about acculturation, how kind of becoming more enculturated, becoming more embedded in the larger American society, for some, might make it more acceptable to participate in mental health care. So I want to spend just the last, I think, 2 to 3 slides transitioning a bit from mental health outcomes to talking a little bit about what's been widely reported in the news in terms of disproportionate impact of COVID on the African American community. Once again, you see a similar map. Once again, you see this is a map displaying COVID deaths across the city. And once again, you see that the heat marks, the dark blue is located on the south side and the west side. And so this data, it was the most recent data that I could easily find. I don't want to claim that there's not more recent data that reported that while 23% of residents in Cook County are Black, 58% of COVID deaths have been among Black residents. And while 29% of Chicago residents are Black, over 70% of COVID deaths in Chicago have been among Black residents. I think we can point to many, many reasons why this is the case. And, you know, in the news reports that I've read, and of course from my own clinical and research experience, I think it's accurate, those that have put forth the statements that COVID is really just amplifying the health disparities, the broad health disparities that have already existed in communities and in the African American population in general. We know that African Americans disproportionately experience the underlying health conditions that put them at greater risk for COVID, such as diabetes and hypertension. We know that they're more likely to have some high-risk service jobs, so working in grocery stores, working as CNAs or medical assistants, where not only are they unable to work from home, but they might be directly coming into contact with individuals that are positive for COVID. There's been a number of articles that have pointed to Black residents living with more people in the home. So you have more people in the home, not only is it more difficult to self-isolate, but you also may have more people that are coming in and out and bringing the risks that they face outside of the home back into the home with them. And then prior to this, this is just amplifying the challenges in access to healthcare that already existed, whereby those who are at risk are also experiencing more challenges getting tested. So for you and I and our friends and loved ones, what can we do to help manage our own stress and mental well-being during this continued pandemic? I didn't really talk about my mindfulness background today, but that is an integral part of my work. And so I start by suggesting that you be present. Right? The only moment that we have is right now, and while I feel the urge, and many of you might feel the urge to continuously wonder, what is this going to look like in the fall? What is this going to look like next year? All we have is kind of this day, and maybe at the most this week, that we can really kind of look to with any mild certainty. In that being present, noticing the emotions that are showing up. A lot of folks are feeling stressed, are feeling anxious, maybe even feeling depressed. In my clinical work, I'm seeing more panic showing up. A lot of that is related to the feelings of uncertainty, the sense of feeling out of control, the sense of being overwhelmed and frustrated. And so just noticing that and acknowledging it and allowing it to be, to some extent, allowing yourself to experience those emotions. Letting go of that which is out of your control. For many of us, when we return to some sense of normalcy, is out of our control, right? But we might have some control, at least some mild control, over establishing a daily routine, over setting some boundaries in our personal and professional lives. And those are things that we can kind of grasp onto during this time. Being sure to stay connected to friends and loved ones. I recently had my book club on Zoom, and that was amazing. I've recently also reconnected with high school friends that I haven't, talked to in many years, and that's also been amazing. And so, while it may sound a little cheesy in this time of high stress, perhaps there are some glimmers of opportunity that we can use to connect to the people that bring us joy and connect to the things that we love that bring us joy. Being kind and compassionate to ourselves, just doing what you can each day, not holding ourselves to the same expectations that we might have had in our routine lives prior to COVID. Setting limits to the news that we watch, knowing that checking the news constantly, while we might feel an urge to have as much information as possible, this can sometimes backfire and lead to more anxiety and panic. And if you're having difficulty managing your mood and stabilizing your mood, absolutely seeking help if needed. I know Northwestern is providing telepsych services now, and many other institutions that previously were not providing telepsych are now allowing those services. That's the end of my comments for today. I appreciate all of you that signed on for this webinar, and I wish you all well. And I think that we're taking a couple of questions.
Yes, thank you so much, Dr. Burnett-Zeigler. Yes, we will be opening up to questions. If you use the chat feature to send Ivy any questions, she will bring those up right now. Ivy, any questions in the chat?
Hi there. Thank you. I think our center's director, Dr. Melissa Simon, has a question. If Dr. Simon would like to unmute herself and ask the question. Thank you.
Hi, Inger. Thanks so much. That was amazing and spot on in every way possible. I just wanted to ask, as you've transitioned your work and mindfulness with that clinic to online, how did that work?
Yeah, so at the time that we made the decision to transition, we were at week 5 of the 8-week intervention. And so we had just finished week 4. The group is on Wednesday. And so that Monday, we did kind of crash calls to get everyone set up on Zoom. I have to say, you know, there were some minor hiccups, but overall it worked okay. Our participation was pretty much as consistent as it had been with the in-person groups. We were concerned about people having the technology and the internet connection availability in order to be able to do it virtually. And fortunately, with this cycle, that didn't present itself as a challenge. And so I say for our, you know, for our first run, and by it being kind of, you know, last minute, it went okay. Right now, given the level of uncertainty with things going forward, we're probably going to hold our next cohort virtually as well, and that'll be in July.
That's amazing, because even though you may be changing your aims, the contribution of being able to show a tele version of mindfulness therapy for multiple people, that is so needed, like in so many fields. So yay, I'm impressed.
Thank you, Dr. Simon.
Thank you. I have a question from the audience. Is there any information that compares mental issues between first-generation and second-generation immigrants, Asian immigrants, due to broken ties with culture and heritage?
So I don't know specifically around broken ties with culture and heritage. However, I do know that in the study that we looked at as a part of acculturation, we also looked at years since immigration as one of our ways of examining acculturation. And we found that those with greater years since immigration were at decreased risk, right? So those who were more recent immigrants had more challenges, if you will, and that's consistent with the literature that's looked at other health outcomes, other negative health outcomes like eating behaviors and smoking behaviors. So that's the literature that I know that I think is most closely related to the question that was asked. Thank you for that.
Thank you. And I have one question from Springfield, Illinois. There's a higher percentage of elderly. So the question is around loneliness and isolation our elderly may be feeling. How do we outreach to help combat this?
Yeah, so I think that's a really important question, and I've been getting that question a lot. And a lot of folks are, been using Zoom in creative ways. And I know that technology can be sometimes a challenge for our elderly population. And so, I remind folks that the phone is still available, and reaching out to friends and loved ones in an intentional way by phone can be an important piece of helping people feel less lonely and feel less isolated. With the clients that I'm seeing virtually, we've been actually creating contact lists for the week, and that's not just the elderly, but kind of across the age spectrum, so that they can not only feel connected, but feel connected with individuals that are gonna kind of bring them some joy during this difficult time.
I have two more questions. For many health providers, any Black person is African American, yet for recent Black immigrants, the challenges are quite different. Languages, too much trust in authority, contrary to what you mentioned among African Americans. Could you speak to that?
Yeah, I think that that's quite true. James Jackson out of the University of Michigan has done some work around that area, looking at differences in the prevalence of psychiatric disorders among those that might identify as African American, in contrast with other African heritage immigrants. The issue of trust with providers is not one that I have looked at, and I wouldn't be able to speak to that piece specifically, but I think that that is an important point, an important distinction for sure.
Thank you. I have one last question. Can you share culturally relevant client engagement strategy used to recruit participants?
Used to recruit participants. Oh, sure. So, I think that Chet is really all about this, and so I appreciate that question. I think becoming engaged in the community is really the most critical first step. And so with my team, I really underscore having a visible presence, understanding the community with which we're working, not only from a work perspective, but if you will, kind of a lived experience perspective, understanding cultural norms and events and leadership in the community, so that when you come in as a researcher, you are already demonstrated that you've kind of done your homework and you understand the norms and practices of that specific community. Another thing that I would really underscore is, for lack of a better word, deference to the community members, letting them be kind of citizen experts in terms of teaching the researchers and the staff about kind of how things are done, not only in the health center, but at the community at large. And then on a more concrete level, thinking about language, and I mean that even for English speaking populations, in terms of terms that are used and phrases that are used and images, and making sure that those types of things match and reflect the population that you're working with.
Thank you so much, Dr. Burnett-Zeigler, and thank you for everyone that joined our webinar today. We are working on getting some of these webinars on our website, so stay tuned, check out our website, sign up for our newsletter, and like I said, check out our Skinny Trees podcast with our COVID-19 mini-series. And thank you again for joining us.
Thank you.
Bye.
Bye.